Okay, we can move on to another video. I've consciously not taken a break here because we're going along. You guys have also had coffee and stuff, so if you need to do something, then please just carry on. But we will look at the video of Sophia and PTM now. So another one of John's videos. I'm loading it. So why don't you guys start by telling us what was in that video?
It was a video of a gastroscopy, and especially also the preparation of the gastroscopy. And that was what, to me, was what struck me maybe the most, or what I liked the most about the video, is I think you took about 5 to 7 minutes just talking to the patient, just explaining what you're going to do and explaining what you're going to feel, that she shouldn't worry and everything. And I really liked that. Also, as was explained yesterday, checking the scope very nicely, making the tip bend before entering. So the preparation was, to me, what was I think very important in this gastroscopy, and it's something that is often forgotten, I feel. And trainees, they want to start gastroscopy, they want to get on with it, and I think those types of operations are the things that are is what most trainees are struggling with, and also what probably increases tolerance of patients a lot. Also, especially in the non-sedated patients, I think that is what helps a lot, but is often forgotten. So yeah, really, really like that.
Okay. Sophia, did you have some comments?
Also, Professor Anderson talks to ask a patient about a symptom, and after he drives the procedure on the basis of this, the patient complained dysphagia. So he looks at the esophagus very well, not to miss lesions in the upper esophagus, for example, Zenker diverticula. After he looks the distal esophagus, and he looks at the peristalsis, so he can rule out also motility disorders. And also he looks at very well the GOJ junction also in the retroflexion during a retroflexion maneuver. Yes. You
got some comments hearing that, John?
Yeah, I mean, it's my standard practice. So we're training people to develop their ENTs, and I mean, you also talk about pre-test probability of this, that, and the other, and I think this is an area where the relationship between symptoms and pathology is not always there. So, however, there are certain symptoms which I think require a bit more attention, and dysphagia is one of those. So, I think during dysphagia, it's not just is there a physical obstruction, but is the motility normal? Is the esophagus dilated? Are there any changes to the mucosa? Again, you're looking at the OG junction. Is that lax? Could that be causing a problem? Even if there's not active reflux, because the reflux can be healed with proton pump inhibitors, but they may still be getting some reflux symptoms, and some of those might be perceiving those as dysphagia. People use the word difficulty swallowing to mean lots of different things. So having a brief conversation with the patient about exactly what they mean by their symptoms and how long they've been going on helps you in your head formulate what you should be looking for. But there are some generic things there, and as I said, in the esophagus, it's not just the visible abnormalities. Is the motility normal? Does the esophagus appear dilated, etc., etc.?
Yeah, I think that's very important what you said there about pre-test probability. I think people are, for some reason, I don't understand why, very bad at that. They're kind of just sometimes surprised when they find things, or they say they're giving negative exams for things where, and I cannot believe what I'm reading, that someone's done a negative exam in the context of severe melena or something, and they haven't signposted the patient to other treatments. So I think that's very, very important. Talking to the patient, very important. Yeah, I agree with all that. Other stuff you took from this video?
Also, it checks also the scope, but also if nurse staff is ready.
The what? Sorry, I didn't understand.
The
nursing staff is ready.
Yes.
Yeah.
Yes, it is very important because we work in a team, and also above all in a colonoscopy, 4 eyes are better than 2 to look for a polyp. but also in a gastroscopy as nurse staff is very important to take biopsies or other stuff.
Something about empowerment there, right? Empowerment of the nurses to say something. I think if the nurses are prevented from saying things, a lot of my nurses are absolutely empowered. Like they pretty much say anything they want, maybe sometimes too much. But that means, of course, that they say when they see something, they don't mind to just bring it up. And of course, this should be the culture you have, because if you don't have that culture, and I know John has that culture because he trained me, I know Roland has that culture. If you don't have that, you don't learn anything. In fact, you might as well just do your own practice in a dark box and never want to learn from anything. So I think that's a really important comment that you made. And John, any others comments on that?
No, I think appreciating your team is key, David. Undoubtedly, you are in charge of the procedure, and the safety of the patient's welfare ultimately is your responsibility. But really, you cannot function effectively endoscopy without a team around you, and therefore you should take care to ensure that they are part of the whole service, really, and allow them to develop within your service as well. So there are opportunities for them to learn. So they can be quite interested in, as particularly if you're looking for abnormalities, they become quite attuned as what normal is and is not normal, because they work there every day. They look at the screen every day. They've probably seen more procedures than us. If you train them, they'll pick up the abnormalities eventually.
Okay.